hormone replacement therapy, bioidentical hormones. These are big topics that I often get lots of questions about. And there's so much information out there that it's difficult to sift through it all. Joining me today is a top expert in the field to help us make sense of it all. So I'm here with Dr. Anthony Bazzan from the Marcus Institute at Thomas Jefferson University. He's an expert on women's health, hormonal health, medical mysteries, and so much more. Dr. Bazzan, welcome.
Thank you. As usual, a pleasure to be here with you.
So Dr. Bazzan, we've spoken about menopause and some of your approaches to help women go through that process as stress-free and as comfortable as possible. But every once in a while, I encounter women who, despite doing those good things, it's still not quite enough. Do you see that as well?
Certainly. Even when a person does all she can to be all that she can be, substituting for the lack of hormone production is an impossible mission. So over time, the question became, well, if the problem is the loss of hormone, what could we do about that? Could we put them back? Mm-hmm. And that was the beginning of the notion of hormone replacement therapy. Not a bad idea. You know, hormone means I make things happen. And they do. Because when they leave, things don't happen, right? And we call them, interestingly, in medicine, we call them the minor hormones. Because you're miserable, but you're still alive. Mm-hmm. The major hormones, they go, you die. You cannot deal with without cortisol or thyroid, you just die.
And these minor hormones that you're talking about,
estrogen, progesterone, testosterone, DHEA, these are the things that keep you, so to speak, younger and happier. And so the history of hormone replacement therapy, as you know, is fraught with good points and not so good points. Progesterone was invented, found in 1929 in London. And right after the war, the pharmaceutical industry was able to create pretty much hormones at will because they had the ability to do so in a lab. They could put pieces on the molecule, change them, place them whatever they wanted. And that was the beginning of the world of hormones that we know today. And so the first thing pretty soon they realized that they could be used as, anticonceptional. They could be used as birth control pills, which was sorely needed because in the mid 50s on, the sexual revolution came and women wanted to have options, and rightly so. Eventually, people started thinking, this Dr. Wilson wrote a book based on 15 women, called it Feminine Forever, and that took the world by fire and then started the idea of doing hormone replacement in perimenopausal or postmenopausal women. And that all happened, and then eventually, though, people started seeing that there were issues with blood clots, there were issues with cardiovascular, there were issues with cancer. And on it went till the fateful month of July 2002 when the monster WHI, Women Health Initiative study hit, showing that current therapy with known human hormones created an excess, not by much, by the way, but creating an excess cancer rate and cardiovascular issues, including blood clots, strokes, and venous thrombosis and all that.
So at the time, up until that study, people were using what you're calling non-human hormones. Can you describe what that is a little bit more?
It means that the formula is being changed in the laboratory so that you can patent it and sell it as your own. Because you cannot patent a human formula. It's not allowed. So you cannot go to market with natural progesterone. You cannot go to market, they can now with some hormones. But proprietary formulas is how it's done.
And so these problems that we're seeing in peri and postmenopausal women from the WHI study, those results were more problematic than what people see in younger women who take the birth control pill?
Completely different world. The fact that they're younger women, basically they can get away with it, they can do it. Mm-hmm. Every once in a while, maybe you'll have a problem with a particular person, but that's a rarity. Mm-hmm. Whereas when you fast forward 30 years and now the woman's 50, things change.
These artificial hormones are too harsh on the system.
Right.
They're really meant to suppress ovulation And you don't really need that powerful of a response in a peri or postmenopausal woman.
That's right. And so the product that was used in the study, Prempro, was a mixture of horse estrogen that came from the urine of the mare, primary pregnant mare urine, coupled with a non-human progestogen. It's important, actually, I want to spend a second there. Progesterone, in reality, is what your ovary used to make. Progestin, T-I-N, or progestogen, G-E-N, is the pharmaceutical that is not at all what your progesterone is. Unfortunately, it gets called progesterone. So the confusion is massive at all levels. But now, after 20-some years, tons of studies and experience, I have a much clearer picture. First, the Premarin, although not human, was not responsible for the strokes or the cancer increase. It was, call it the fake or the non-human progesterone that did all that. The medroxyprogesterone acetate. And the literature's clear on it. Just to give you an idea, 1 milligram of that medroxyprogesterone acetate has the biological power of not 4, not 40, but 400 milligram of a woman's own progesterone. Wow. So it's 400 times more powerful, and the pill contained 5 milligrams. So I treat my women with 100 milligram, 200 milligram, sometimes 300 milligrams
of natural progesterone.
Whereas that treatment was the equivalent of 2,000. This is in the books, so it's not even a matter of study, it's common knowledge. So you can see how, I jokingly say to my patients, the fact that a little salt is good in the soup doesn't mean the 5 pounds of salt is good in the soup.
So when you're doing bioidentical hormone replacement with women, you're using natural progesterone or the biochemical formula of progesterone that...
Yeah, you can call it natural to a human.
Right.
In other words, it's got a precise formula.
It's synthetically made.
But it's completely identical to the one that the body has grown or was built with. If you think about a car, that's how that car was built, and that you go back to the dealership because you don't want another car piece in that car, right?
So tell us a little bit about the estrogen replacement, because not only are you using a bioidentical preparation of the estrogen, but in addition, you tend not to give it orally, correct?
Yes. Now, why is the delivery system important? Because when you orally ingest these hormones, they go through the liver. Everything goes through the liver, right? So you have to go, once you get past the stomach and all the processing happens, you end up in this short segments, the duodenum, the jejunum. That's where you cross inside the body. Up to that point, you're still not in the body. You think you are, but you're not. So once you come across the gut wall and cross that, now you're on a highway called the portal vein that can only go to one place.
The liver.
Now, that's where the clotting factors are made. And, in medical language, we call that the first pass. So, if you eat substances that multiply the production of clotting factors in the blood, in the liver, and then they leave the liver and start floating all over the place, that's not a good idea at all. Because now you're asking to shut down blood vessels and getting problems. Mm-hmm. That's why we're extremely careful when it comes to that.
So how do you give the estrogen?
We have creams, gels, and we have patches, maybe the most common. And also we can put them under the skin with pellets that are tiny grains of rice that maybe are the closest to imitate the ovary that you can get, because it should be always remembered that the ovary secretes the hormones in the blood. So if you look at all the delivery systems, only the pellet can do that.
And all of those delivery systems are bypassing the gut.
Yes.
Now, why is it important to bypass the gut for estrogen, but it sounds like it's okay to take it orally for progesterone?
What a great question. I was hoping you would ask that. That's a phenomenal story. So in the gut, you have these things called villi, villi, and they're like the bristles of the brush. If you look inside the villi, there are structures and channels and canals, right? And one is these canals, which belongs to the lymphatic system, right? It's called lacteal. These lacteals are responsible for the absorption of fats. Now, progesterone, and I'm talking about now natural progesterone, micronized, bioidentical, the woman's own stuff, right?
Yeah.
When you eat that, depending on the woman, it could be maybe even 50% of that progesterone is going to go into the bloodstream away from the liver because of the lacteals. Imagine that they're like canals.
Right.
Okay, pipes. So you're going to that city, and you're not going through the city called liver, you're going in another highway. And that is exactly what you wanted to happen, because this way you don't go bother the factory of clotting factors.
Right.
That is the one that you're worried about. This is, it just happened like that, but this is what I call the blessing of, how the body handles oral, natural, micronized human progesterone.
And the body doesn't do that when it comes to estrogen or testosterone.
Exactly. Patches, creams, and gels, we use them all the time. A lot of women love the pellet because you put it in and for 6 months you're done.
Why is it important to take progesterone with estrogen therapy?
The number one reason is to avoid bleeding, right? Estradiol will thicken the lining of the inside of the uterus, and progesterone will shave it off. One for bleeding, and the other one, the remote possibility that if you do estrogen continuously without progesterone protection, you might get uterine cancer.
So does progesterone have any other benefits besides protecting the uterine wall when somebody's on estrogen therapy?
Yes. And this is one of the most favorite properties of progesterone that women absolutely adore. Because of the action of progesterone on the brain, progesterone is an anti-anxiety and puts people back to sleep naturally.
So just to summarize, the loss of estrogen is causing which symptoms, and the loss of progesterone is causing which symptoms?
So let's divide the downstairs and the upstairs. So the lack of estrogen is less trophism of the urogenital tissues. So vaginal dryness, bladder not functioning as well, aging, drying up and all that. But all these hormones are absolutely necessary in the brain. Matter of fact, now there is a new field called neurosteroidology, which occupies itself with nothing but this. The effect of these hormones, they used to be called sex hormones. Now we know better. They call them, brain hormones now. But neurosteroidology was created in the year 2000. So this is a 24-year-old field that is very active. And I can absolutely testify to that, because it's the lack of estrogen that makes the woman say, I have Alzheimer's disease. I can't find my car keys. I don't know what I'm doing. I forgot that. My kids, that's the estradiol part that goes away. When the progesterone goes away, what happens is anxiety and insomnia. Why? Because the brain uses those to take care of those two issues, right? And let's throw one in. The last one, the testosterone for women, it's the antidepressant, and that's another incredible, beautiful property that it has.
And it's also important for muscle and bone health too.
Yes. Testosterone is the biggest anabolic. If you want your bones back, if you want your muscles back, that's what you need.
A lot of women think, it's testosterone. I don't need that. That's a male hormone.
Well, see, the thing is that we have 20 times more testosterone than they do. That's why we have a male body. And this is why you got football players, right? The women have 20 times the estrogen that we have. That's why they have a woman body. Obviously, that creates a bone mass and a muscle mass clearly smaller and inferior to the one that we have. So the testosterone for women, because they have so little, becomes almost like a precious commodity, because they already started out sort of at a disadvantage. And when they come into me with 0 levels, well, that's a huge part of sarcopenia, which is how we call loss of muscle, osteopenia, that then becomes osteoporosis. And so bringing back a little bit of that, not like us, man, a little bit of that for them, it's one of the most rewarding things I do in my practice.
Wow.
Not only for the bones coming back and osteopenia and osteoporosis, but the way they feel. Because I say to them, testosterone will make you say, I'm 60 years young instead of 60 years old. It's a motivator. It makes you say yes instead of no. Do you want to get another client? Are you crazy? I mean, are you kidding? I am too tired. Now you go, oh, okay, we can do that. Or you want to move? Okay, get a new home. Instead of, no, that's a completely other question. So, and that's all brain function, neurosteroids.
So how do you know how much of these hormones to give a woman? Is it sort of a one-size-fits-all kind of thing?
The blood work is very helpful because we can see levels.
So you're looking at levels of estrogen and progesterone and testosterone in the blood.
FSH, very important. And the rule is you ease in. You don't barge in. So you go very slowly with small doses so that the system says, oh, look who's back. Where you been, right? About time he came back to work. And so when you do it like that, it works very well. You don't run into these, and the rule is the older they become, the less they get.
Okay.
Not the opposite. Because the metabolism is slower, the action runs longer. So every time is I call it painting the patient. In other words, you do what's right for that person.
So I'm not a women's health expert like you, but I do see an increasing number of women in my executive health program. And I'm starting to see this trend again of perimenopausal, menopausal women who go to one of their doctors complaining of symptoms, and they're being put on the birth control pill again.
Yes, that's that has to do with how medicine is taught and standard of care. So, although many physicians are aware of what happened with the WHI study, and they don't go there. But more and more studies around the world, and everything I say, I read it in the literature. And I couple that with 25 years of experience with hormones in women. And we have been very happy with our results. And, we understand the concerns and all that, but we don't run into those problems. And I'll give you one more. Estrogen, it needs to be policed because estrogen can change. We call them metabolites.
So you're looking at these metabolites to make sure that women aren't making a bad form of the estrogen.
Exactly. If a woman comes to us and we do the analysis of these metabolites and we see that she's preponderantly transforming estrogen from benign to dangerous, we say, this is not time for hormone replacement therapy for you. We need to fix this first.
I think the take-home message there too is the hormone replacement therapy might be necessary, but it's not sufficient. The rest of those lifestyle things that you put into your program, such as the right kind of diet, particularly the right kind of diet, are really critical for that bioidentical hormone replacement therapy to work its best.
It's a great point. It's a wonderful point because they come in for hormone replacement therapy, they walk out with a whole rehaul of their lives.
Well, Dr. Bazzan, I always learn something from talking to you. Thanks for joining us today.
My pleasure again. Until next time.